In the PACU or the OR, I work in the ICU, taking care of surgical critically ill patients. We are all being asked over the next couple weeks to start transitioning our care to patients with severe manifestations of COVID-19. So I'm going to give you just a little bit of perspective of what these patients look like, not physically look like, but in terms of how they'll present to you in the new respiratory ICU. And then some thoughts and considerations about our approach to treating critically ill patients who you might not have ever seen before. Can everybody just mute their microphones so we don't get any feedback? And unmute if you have a question. Okay, great. So, overview, I'll just give you a little bit of introduction of how we sort of approach these patients and the nomenclature of this disease. I'll talk about briefly the clinical course, what to expect. These patients do not get better fast. If anything happens fast, they decompensate fast and they get better slowly. Talk about the next step, some treatment considerations, and then, ultimately how many of these patients get better and how many of these patients don't get better. And then we'll open it up quickly to questions. You guys will have your own dedicated team of physicians on the third floor, headed by Dr. Natalia Vasquez. She's the medical director of the cardiothoracic ICU. She will be your point person. Anything that she says will trump anything that I say. This is just an introduction to get the discussion started. SARS-CoV-2 is technically the name of the virus. COVID-19 is the name of the disease. In the same way that HIV is the virus that causes AIDS, SARS-CoV-2 is the virus that causes COVID-19. There's a lot of information flowing around in social media, some of which is true and some of which is not. And then we all discuss and use different nomenclature. I just think that it's important to get everybody sort of on a good baseline, if you're not already. Hopefully, we're all fairly well aware of the risk factors and an emphasis on severe COVID-19. We're not talking about moderate or mild COVID disease, but 95% of folks who live out in the world. And if you get this disease, it's 95% chance it will be mild to moderate. The people that you will see, the people that you will admit to your respiratory ICU these coming weeks are people with severe disease. That's all that I'm talking about. So the severe disease carries with it certain mortality implications and certain treatment considerations. But these are the risk factors that we know of. Folks who are older and with pre-existing comorbidities, these are the comorbidities that we talk about. Certain vital signs you don't necessarily need to worry about if they're getting to you, it means they have it. One of the hallmark signs of this condition is rapidly deteriorating hypoxic respiratory failure. So the clinical course is the initial decompensation. We probably won't see these patients until they decompensate, either in the ER or on the hospital floor. With any luck, we have a huge team of anesthesiologists who run around the hospital intubating these folks. So the goal would be that they're intubated before they get to us. With that said, in the age of, we may not intubate all of these people with severe respiratory decompensation yet. There may come a time where we actually admit somebody on high flow or BiPAP. Again, the hospital's driving this. There's a lot of decisions that are made by the medical ICU team. We have to be prepared and ready to treat people who are intubated. And potentially, again, these aren't my decisions, and we're not there yet. But we might actually be managing some patients in the future on high flow oxygen or CPAP and BiPAP. If that's the case, we will make sure you're well trained and well prepared to do this. But expect to receive a patient who just got intubated and who might need to have a couple lines placed, like a central line and an arterial line. The traditional workflow would be a patient decompensates in the ED. Dr. Turnbull and others will swiftly go down when asked by the medical ICU team to intubate them. We have pretty much every OR anesthesiologist that's not working in the ICU is on the airway intubation team. They are on the front lines, putting breathing tubes in these patients, and then sending them to us being the ICU team. And we all together on this call are part of the ICU team. They develop a condition called ARDS, acute respiratory, I'm blanking in the acute respiratory dysfunction syndrome. So that ARDS means a lot sort of medically without getting into. They're intubated on average for 10 to 12 days. Yes, that's right, 10 to 12 days. So the ones who get admitted to you, you sort of want to know the day they're intubated And also in sort of, some people, that's average. Some people may get better quicker, but some people may take longer. But that just is to focus you and puts you in the right mindset of how long it takes people to actually come off the ventilator. This is a long and complex clinical course that requires a lot of intricate thinking and troubleshooting. These patients are, especially at the beginning, are deeply sedated. Some are even paralyzed with neuromuscular blockade, and a select few are even prone, as well as treating the ARDS, as a way of treating the ARDS. Right now, and this isn't to demoralize anybody, right now with the best treatment, so just to make it clear, there's a lot of talk about medication and drugs. All of those are good, but there's no known and acceptable true medical therapy, no known drug that actually helps treat COVID-19. With that said, it is very clear that with timely, appropriate, and precise critical care, that those who can survive this will survive. So the best drug, the best treatment is everything that everybody on this call is working to do. That is the best treatment for these patients is intubation and critical care, all of which you are all integral in helping to deliver. Drugs, we are like chloroquine, azithromycin, remdesivir, you name it. It is being studied, and it's being studied here. We're the best hospital in New York, so we're on the cutting edge. The ID team and the MICU team is driving administration of those medications. We work in conjunction with every one of these patients, so every one of our patients will be given the best, most up-to-date care. But know that the medicines that are being researched are in the hopes of the future might help the course of the disease. That should not supplant what we do every day and the apt critical care that we will be delivering. That is the best treatment. If so, then at least then our goal is to help 75% of these patients with severe COVID ARDS survive. If you read the numbers and if you look at some of the data is really poor. But the mortality estimates are actually higher in some small studies. We don't need to get into the estimates. We believe that we're going to give them the best and most up-to-date care, so we're going to push that curve, and maybe we could even get more than 25% of these patients, or more than 75% of these patients to survive. That's what we're working hard every day to try to figure out. But don't be surprised and don't be concerned. If somebody is passing away, it doesn't necessarily mean anybody made a mistake. There's a big question about what to do in patients who are so sick if and when they do go into cardiac arrest. So it's worth noting here before we go in to ask questions, maybe to help dispel some concerns. These patients are critically ill. Patients who are critically ill are prone to decompensating. Doesn't mean anybody messed up. And they're also prone to going into cardiac arrest. Those, we don't operate in the operating room. It's rare for patients to go into cardiac arrest. It may be clear that some of you have never actually participated in a cardiac arrest except when you get recertified for ACLS. Mentally prepare yourselves that this may happen to your patient. With any luck, it won't. I'm not trying to say it will. But start getting mentally prepared for what's about to happen. The respiratory ICU is expected to fill up. I know there's only a handful of patients there now, but I promise you, I would love to be wrong, but we are expecting the respiratory ICU to be full over the course of a week or two. And I can't tell you when it will fill up, but very likely it will. So take this opportunity to sort of remind yourselves and really truly train for the real deal that's about to happen. Anytime your patient changes in clinical status, do what you're trained to do. Alert others, call for help, and put your PPE on, okay? Don't run into the room without any PPE, because that's not going to do anybody any good. You're only going to expose yourself to the healthcare provider. You might actually expose other people who are responding to your call for help. And the patient who's already in cardiac arrest, you're not going to help them any more than you could have a minute ago, right? So it's definitely something that we have to grapple with. But if you run in without your PPE, not only is the patient going to do poorly, but you yourself and others who respond to that cardiac arrest might actually do poorly too. And that's what we're really trying to avoid. With the critical care of these patients, that we're trying to avoid this situation. If it happens, it happens. Do what we normally do. Move swiftly. Anytime an order is written, we move swiftly to get the drip and to hang the drip. Anytime somebody's in pain, we move with alacrity and we go to the Pyxis and we pull out Dilaudid and we give it. Anytime we have a change in patient condition, you move swiftly and with dedication. But don't be unsafe to yourself or those around you. Prepare yourself for the long haul. Take the time to properly protect yourself before you go into the room. Keep the doors closed. And understand and remind yourself that ACLS sometimes is not effective at reviving these patients. Mentally prepare yourself now. It can be tough the first time you've seen somebody pass away due to ACLS in this condition, but it does happen. The heroes in a pandemic are ordinary people with extraordinary opportunity to have effect on those who need it. This is you and all of us. During times of calm and emergency, act the same. Be calm, move deliberately, do not rush, do not cut corners, protect yourselves and those around you. Anybody who's read The House of God, the first thing to do in an emergency or a cardiac arrest is to take your own pulse. Calm down, take deep breaths, do what you've trained to do. There will be those around you who can direct you and they know what to do, and work as a team. We're all part of this extraordinary team that's coming together to do something that's never been asked to be done in history before, modern medical history. It's completely normal to have questions and concerns, and that's what we're here to do. We are all one team. The message will rapidly change, so if you're getting conflicting messages, you will quickly learn why, because we're still developing what we do as we go. But you'll understand sort of the hierarchy and how information flows, and we're all rapidly working together to deliver care. Understand that daily the care of these patients change. We understand how to do it better. We learn from what we do, the same way that NYP constantly is sending us care updates and updates on PPE. Don't be concerned if we come in and all of a sudden change our plans. We may have an update. This is not outside of our skill set. However, we might not be used to it. We all are learning, and we all will adapt together to the care that is needed. At all times, you will have a dedicated physician and practitioner staff dedicated to your floor alone. Dr. Natalia Vascu is the medical director of the CTICU. She's written the book. She's trained me and others on how to deliver critical care. So you've got the best down there working with you this week. She will continue this process and work to develop the system down in our respiratory ICU. You are all the experts of how the third floor runs. Your care team is and will be the experts in the care of these patients. Together, we will work to deliver complex care to the patients most in need. What does this mean for all of us? This is a picture of currently what's going on in the ICUs. Every one of these patients is intubated and sedated. This is the amount of drips that each average patient is on. The care for these patients is a lot of hard work. Prepare yourselves. This is the care team. This is what they look like. They're all in masks. They're all in caps. In general, we're not even going into their rooms. We minimize going into their rooms unless something's actively needed. We examine them from the window, mostly to reduce exposure and reduce PPE. Obviously, if something is needed, we will, as a care team, go into the room, especially during admission when we have to place lines. But a lot of times when we get to the subacute phase, day 3 to day 10, when we're just waiting for their lungs to recover, a lot of it is just waiting and tinkering. You do not need a fellowship, board certification in critical care medicine to help give a true mortality benefit to these patients. With the application of precise critical care medicine, that is the best drug. Everything you guys are working to do today and throughout the week is giving these patients the best treatment that we have available. Any observations from every team member at the bedside, especially you and those at the bedside, are vital to our ability as a care team to take care of these patients. With that said, I'll stop and open it up to questions here. Let's see if we have any. Okay, no questions in the chat. Anybody, fire away with your questions. I've got until 9:30.